Welcome to Cardio Radio, a podcast of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardio. This is Dr. Michael Constant from the Case Western Reserve University School of Medicine, and I serve as the principal investigator for Cardio, a statewide network of Ohio's 7 medical schools. Cardio is funded by the Ohio Department of Medicaid and shares best practices to improve cardiovascular health, diabetes outcomes, and to eliminate health disparities in Ohio's Medicaid population. The opinions and recommendations in this podcast are those of the presenters and not those of Cardio and its sponsors, and are not intended to be a substitute for medical advice. I hope you enjoyed today's podcast.
Hello, my name is Dr. Lauri Nandyal, an associate professor of family medicine at the University of Cincinnati and a member of Cardio's Team Best Practices. In this podcast, we will discuss the importance of oral health and its bidirectional relationship with cardiometabolic health. We will review their common comorbidities and the multifaceted relationship between oral disease and systemic health concerns, as well as the effects of systemic disorders and some medical treatments on oral health. It is my pleasure today to welcome Dr. Yi-Chu Wu, an assistant professor of periodontology at the Ohio State University College of Dentistry. Welcome, Dr. Wu.
Thank you very much, Dr. Nandyal, for the invitation, and thank you to Cardio for the opportunity. It is my passion to share and emphasize the importance of oral health and how it links to and affects the whole body health.
Great. Dr. Wu, would you share with us what your motivation as a dental professional is for joining us in this conversation?
Absolutely. My motivation for joining you today stems from the statement that the mouth is the gatekeeper to the body, and that oral health is not separate from overall health. It is an essential part of it. In my practice, I also see how oral conditions are deeply tied to systemic health, particularly with cardiovascular disease and diabetes outcomes. These are not just dental concerns. There are also medical concerns. Oral health often remains siloed when we talk about health, and it is viewed as a separate form from general medicine.
Thank you. Let's start with a landmark 2020 National Institutes of Health report on oral health in America. I know that many of the things we'll discuss in this podcast are in this report, so we'll definitely link it in the show notes. Among other things, the report emphasizes the fact that many oral processes, such as tooth and gum disease, dry mouth, as well as dental loss, share common upstream risk factors with disorders such as diabetes, obesity, and cardiovascular disease. But before we dive in too deep, I think we need to talk about terminology, terms that may not be as familiar on the medical side. There's many shared terms that we use consistently, like caries or cavities, orthodontia, bruxism, but there are other terms that are not as yet part of our day-to-day vocabulary. It would be so helpful for you to give us a primer on some of the highest yield terms you wish that we as clinicians knew.
Of course, I completely understand that the terminology in dentistry can sometimes feel a little bit like a different language. Let's start with the term pockets. There's a space between the gum and the tooth, and we call that a periodontal pockets or probing depth. In health, the probing depth would range between 1 to 3 millimeter with no bleeding. In the presence of inflammation or gum destruction, the probing depth starts to increase and the gum bleeds as we probe. One of the common conditions is gingivitis. This refers to inflammation of the gingiva or gums, specifically the soft tissues surrounding the teeth. It is the earliest stage of gum disease, and the hallmark signs are redness, swelling, and bleeding, especially during flossing or brushing. The key point here is that gingivitis is reversible with good oral hygiene and professional cleaning. If gingivitis is left untreated, it can progress to periodontitis. This is a more advanced, chronic, inflammatory gum disease where not just only the gums, but also the supporting bone and connective tissue are affected. Over time, the inflammation and immune response begin to break down the structures anchoring the teeth, leading to gum recession, bone loss, and potentially tooth loss. The primary etiology for both gingivitis and periodontitis is biofilm, which is a structured community of bacteria that forms on top of the teeth.
This is so interesting. I know that clinicians are starting to dive into the relatively new frontiers of the gut microbiome and its effects on systemic health. Tell us more about the oral microbial flora and how it relates to oral health and more systemic health.
Absolutely. You might also know biofilm as dental plaque. It's not just a coating, it's a living, dynamic ecosystem that drives both cavities and gum disease. Periodontitis is not only a localized oral problem, it has systemic implications, and studies increasingly link it with conditions like cardiovascular disease, diabetes, and adverse pregnancy outcomes. Another term that often comes up is endodontic disease, which refers to conditions affecting the dental pulp and the root canal system. This typically results from deep decay, trauma, or bacterial invasion, and these lead to infections or inflammations inside the tooth. When you hear about someone needing a root canal, that's an endodontic treatment designed to save the tooth by removing the infected pulp and sealing the root canals.
This has all been so helpful, Dr. Wu. Now that we have a better understanding of these terms and conditions, would you share with us some of the statistics regarding the state of public health when it comes to oral pathology? What are we dealing with here?
Sure. Oral diseases are far more common than many people realize. Numbers will tell. Over 90% of people have experienced tooth decay in their permanent teeth, and around 27% of that have untreated cavities. On the periodontal or gum side, about 70% of adults show signs of gingivitis, with almost 42% of them having more advanced form of disease, periodontitis. These statistics reflect how prevalent and persistent oral diseases are. However, they remain under-recognized in general healthcare conversations.
These are daunting statistics. What demographics do you find in terms of age, gender, or socioeconomic status?
Very good question. The prevalence of periodontitis tends to increase with age, and older adults from lower socioeconomic backgrounds may have a higher risk of severe disease form. A National Health and Nutrition Examination survey, NHANES, that was conducted in 2011 to 2016 revealed males are generally more likely to experience periodontitis than females. In the same study, we found periodontitis is more prevalent in Hispanic and African American populations, and the disease phenotype is more severe comparing to Caucasians and Asian populations. We also found that individuals with diabetes are almost 40% more likely to develop periodontitis.
That's a lot. Let's pivot to more systemic health issues that you might notice as a dentist. What might you see in the mouth that may cause you to be concerned about more general health conditions beyond the oral cavity?
Great question. The mouth serves as the main gateway to the body. So when I examine the patient's oral cavity, there are several red flags that can raise concerns about systemic health issues. Going back to periodontitis, it's not just a localized infection of the gum and the bone. It's a persistent inflammatory burden. The bacterial biofilm and the result immune response will release some pro-inflammatory cytokines that can enter the bloodstream and contribute to systemic inflammation. This is particularly relevant in patients with diabetes. The relationship is bidirectional. When you have poorly controlled diabetes, it exacerbates periodontal disease. And active periodontal inflammation can worsen glycemic control. On the other hand, providing initial periodontal treatment, such as scaling and root planing, or it's commonly referred to as deep cleaning. By providing these treatments to our patients with uncontrolled diabetes, can reduce the HbA1c levels by an average of 0.6% over a 12-month study period. This finding is based on the data from randomized controlled trials and a meta-analysis. Another important example is oral signs of cardiovascular risk. Several studies show that individuals with periodontal disease have a higher risk of atherosclerotic disease. Studies have also shown presence of periodontal bacteria in atherosclerosis. This tells us that bacteria in the mouth have access to the rest of the body through multiple channels, which include the vasculature as well as the lymphatic system.
This is so intriguing. In systemic health, especially in cardiometabolic fields, we are talking more about the systemic inflammatory burden as well and the role of inflammation in exacerbating insulin resistance and vascular disease. It seems like this is one of those bridges between our professions, strong associations with multiple meta-analyses, while causative explorations may still be underway. Given the more easily accessible oral evaluation of inflammation, it's becoming clearer that oral pathology can really be a harbinger of more systemic concerns.
For sure. Periodontal diseases are themselves low-grade chronic inflammatory diseases. The presence of either cardiometabolic diseases or periodontal diseases may exacerbate one another. We can understand it as a two-hit model that suggests that certain conditions like periodontal disease and diabetes can act synergistically. One disease might weaken the immune system or trigger a cascade of events that makes the individuals more susceptible to the other.
Yes, quite a back and forth. Could you share any concerns you have about other oral health issues that may influence more systemic conditions?
One that comes to mind is mouth breathing, which may seem like relatively minor habit, but it has actually surprisingly broad implications across oral and systemic health. So let's look into it. In children, chronic mouth breathing is often due to enlarged adenoids, allergic rhinitis, or nasal obstruction. And these can contribute to improper facial and jaw development and eventually lead to malocclusion, narrow palate, or even postural issues. These changes can increase the need for orthodontic or surgical intervention later in their life. In both children and adults, mouth breathing disrupts normal nasal filtering and humidification, which can increase susceptibility to upper respiratory infections and contribute to obstructive sleep apnea, OSA. In fact, many patients with OSA are chronic mouth breathers at night. So, from a dental perspective, mouth breathing leads to dry mouth, xerostomia, and it reduces the protective role of saliva. When it reduces the natural protective effect of saliva, it leads to significant increase in the risk of 1, dental caries, especially root caries in older adults. 2, opportunistic oral infection, such as candidiasis. And 3, difficulty in eating, swallowing, and speaking, which will impact the overall nutrition and quality of life. So, when I see inflamed gum without a clear plaque-related cause, especially with redness along the front teeth, I always evaluate for mouth breathing, particularly in children. And I also oftentimes will collaborate and send referrals to the ENT doctors, allergists, or sleep specialists when I think airway is a suspected issue.
Could we also explore the other side of the coin a bit more with you? I'm hearing a lot about calcium channel blockers, medicines like nifedipine or amlodipine causing problems with the gums. Can you give us a better idea of how these and other medications may affect oral health?
Sure, we're definitely noticing gingival overgrowth, especially in patients taking that class of medication. The gingival overgrowth makes oral hygiene more difficult and creates some niches for plaque retention, and in turn, it increases the risk of periodontitis and caries. Some common medication that leads to gingival overgrowth induce calcium channel blockers, phenytoin, and cyclosporine. The other common conditions, xerostomia, as we previously discussed, can be caused by many other cardiovascular medications like beta blockers, diuretics, and ACE inhibitors, plus antihistamine and anticholinergics, some chemotherapies for cancer treatments, as well as some antidepressants medication like the SSRIs. Those might also cause xerostomias too.
What about blood thinners? How might those affect patients' dental care?
Yes, patients on antiplatelet therapies like aspirin, clopidogrel, or other anticoagulants like warfarin or direct anticoagulants may exhibit prolonged gingival bleeding during routine oral hygiene or other procedures. This doesn't necessarily indicate diseases, but it does require careful management and communication between dental and medical teams before any surgical intervention.
That's really helpful. As many of the medications and conditions you mentioned are things that we commonly see and utilize, so thank you for enlightening us about those. Another overlapping issue both of our professions are likely to have to address is tobacco use. How do you address the impacts of tobacco and or nicotine from a dental vantage point?
We definitely cannot talk about oral and systemic health without addressing smoking. It is one of the most significant shared risk factors between our two domains. Smoking doesn't just affect the lungs or the heart. The impact of smoking on the oral cavity is immediate, visible, and oftentimes very severe. It doesn't just yellow teeth. Smoking is one of the strongest modifiable risk factors for periodontitis. The key factor in smoking results in all the bad outcomes is nicotine. Nicotine impairs blood flow, it suppresses the immune response, and it alters the oral microbiome. It makes smokers significantly more prone to bone loss, tooth mobility, and ultimately tooth loss. In fact, smokers are up to 3 to 6 times more likely to develop periodontitis than non-smokers. Smoking compromises healing after dental procedures like periodontal surgery, implant surgery, and extractions. The reduced blood supply and oxygenation hinder the tissue regeneration and eventually lead to more complications and failures.
Could you come back to that concept of the nicotine itself? Any specific oral effects from nicotine vaping without the tobacco, those ENDS, electronic nicotine delivery systems? In my practice, I'm seeing a lot more of that these days than tobacco and tobacco products.
Good point. We realized that not only cigarette smoking, but vaping, e-cigarettes, cigar, pipe smoking, or even chewing tobaccos, they all have negative effects on periodontitis. We also see increasing amounts of e-cigarette users in our practice too. Vaping and e-cigarettes not only negatively impact gum health through nicotine. On top of nicotine, there are chemicals such as essential oils, propylene glycols, and sweeteners that may change the profile of microbiome in the oral cavity. In turn, It shifts the combat between our immune system versus the pathogens. We do not have a substantial amount of long-term evidence on ENDs yet. However, it is growing and we see the trend.
Good to know, Dr. Wu. There's another obvious overlap in our professions when it comes to oral and systemic health, and that's nutrition. Medical clinicians routinely address concerns that we have about refined carbohydrates, sugar-sweetened beverages. All we're thinking as drivers for glycemic dysregulation and inflammation. So let's talk about food.
Definitely. That's my favorite topic. After all, we literally see the first signs of poor nutrition in the mouth. Let's start with this: refined carbohydrates and sugary beverages. From a dental end, we see frequent sugar exposure as the leading driver for dental cavities, especially when the oral hygiene is poor. Refined carbs fueled the acids producing bacteria that demineralize enamel and eventually lead to cavities.
So not only are these refined carbs driving glycemic dysregulation, with some evidence that they work through, let's say, increasing intestinal permeability and the gut microbiome, but they also are changing directly the microbiome profile in the oral cavity itself, driving some periodontal disease. That's fascinating.
Yes, there are multiple, actually 7 control trials that documented an increase in gingival bleeding with more sugar intakes. These clinical trials were conducted on dental students and dental hygiene students who presumably have excellent oral hygiene routines. So we know that sugar really played a significant role in increasing gingival bleeding. Overall, in oral health, we're also concerned about how high sugar diets contributes to chronic inflammation, and it plays a role in both gum disease progression and metabolic dysregulation.
What sort of timeline do you see between oral exposure to the carbohydrates and the oral pathology?
Sure, let's look at how disease or issues develop. Let's first look at dental cavities. In a couple of minutes to hours, sugar that are in the food or drinks will be fermented by bacteria such as Streptococcus mutans and transform into acids. Later, from a couple of hours to a couple of days, those acids attacks the beginning of the mineralized enamel after each sugar exposure. In the same condition, if left untreated or ignored for a couple of weeks to a couple of months, these demineralization will outpace the repair and what leads to some white spot lesions on the surface of the teeth. Later, in a couple of months to a couple of years, if we don't get to address it, these white spot lesions on the surface of the teeth will progress into the dentin, the middle layer of the tooth, and form some cavitations on the tooth. That's called cavitated caries. If we don't get to treat it, these decay could reach the pulp and cause infection or abscesses. On the other hand, when we look at the gum disease profile, it's a little bit different timeline. Within a couple of days, the plaque accumulates around the teeth will lead to gingivitis. We talked about it, it's reversible. There might be some gum bleeding, but overall the bone is intact. However, if we don't get to remove these plaques in a couple of weeks to months, gingivitis will progress, and some individuals may be more susceptible due to genetic or systemic factors than others. So if we don't get to address that in a couple of months to a couple of years, these chronic inflammation will attack onto the connective tissue that cause attachment loss, bone destruction, and formation of periodontal pockets. So if left untreated, these kind of progression will lead to tooth mobility and eventually tooth loss.
Thanks for helping us understand that progression of oral disease. So we've reviewed the diets that contribute to the problem. What evidence, Dr. Wu, do you have about the protective effects of various foods and micronutrients on oral health?
There's big amounts of good evidence on the protective roles of foods. We want our patients to take fiber-rich food or whole foods. These include vegetables, fruits, dairy, and some lean protein. They're not only for systemic wellness, they're also for oral wellness. For example, vitamin C is crucial for gum tissue integrity and the healing around the gum tissues. Calcium and vitamin D, they support bone density for your hip bone, knee bone, and also for your jawbone. Omega-3 may also help with modulating the inflammation, which is helping with healing around the gum tissue.
So, in terms of nutrition, what issues are you able to detect orally, and what steps do you take if an issue is identified?
Great question. So, when I see a patient in my office, we screen for issues like dietary risk patterns, if they are frequent snackers, if they do a lot of soda or juice intake. I also look into things like if they have nutritional deficiencies, especially in older adults or those with some GI or metabolic conditions. I also look into if they have any barriers to healthy eating, and that might be missing teeth, ill fitting dentures, or they have some pain when they're chewing. But indeed, we need to collaborate with our medical colleagues, and that's what we're talking about this together. When we flag poor nutrition patterns, we often refer the patients back to you, especially for signs of eating disorders, possible diabetes, or any signs of malnutrition.
So, Dr. Wu, as we wind up our discussion, let's shift to summarizing some of the oral health guidance and recommendations you'd like us as medical professionals to share with our patients. I'll read each one that you gave us, and you can explain its importance or give some context. Are you ready?
Let's do it.
All right. I heard you say that your mouth is part of your body, and oral health affects your overall health.
So, this helps us to shift the mindset from dental care being optional or cosmetic to being a vital part of chronic disease management.
Another summary I heard you say was that inflammation in our gums can affect our heart, blood sugar, and even pregnancy.
Yes, a brief statement like this connects periodontal health with systemic inflammation and can prompt patient to seek care or really improve home hygiene.
All right. I heard you say that good oral hygiene is preventative medicine.
Definitely. Just like managing blood pressure or cholesterol, brushing twice daily, flossing, and seeing a dentist regularly helps prevent the disease progression.
And I heard you say see your dentist at least twice a year, even if nothing hurts.
Yes, many patients only seek dental care when there is pain, but oftentimes that's a little bit too late. So we want to encourage routine visits to the dentist at least twice a year, and this supports early detection of issues like decays, infections, or even oral cancer.
And then we talked about limiting sugary drinks and snacks because they're tough on your teeth and your metabolism.
The nutrition advice from medical and dental professions should reinforce each other, especially when addressing metabolic syndrome, diabetes, and childhood obesity.
And another really important one you shared with us is that the same foods that are hard on your heart and blood sugar levels are hard on your teeth and gums. Eating well supports your whole body, starting with your mouth.
Indeed, we share the same mind. If we as dental and medical profession can get these messages across to our patient community, that will really go a long way and help our patients to prioritize their oral health. Eventually leads to benefits for their systemic health as well. So it will be great to see some medical clinicians starting to add a brief oral health screening questions to their annual primary visits, such like any bleeding in the gum or any dental problem lately? Or when's the last time you got a dental checkup? Those will really help with reminding our patients to actually go to the dentist. I would also like to encourage sharing the electronic health records between medical clinicians and dental clinicians, or sharing reminders for annual dental checkups, annual primary checkups, or even just referrals, especially in those high-risk populations. High-risk populations, we're talking about patients with diabetes, patients that are pregnant, older adults, or patients with history of gum disease. So reaching out, partnering with dental and medical colleagues could help with streamline the referrals and co-manage patients with more complex needs.
Thank you. We also recognize the difficulty of many accessing dental care, but for our Ohio Medicaid patients, we do have coverage, and we will link that Ohio Medicaid guidance in the show notes. So every time that we as medical clinicians normalize oral health as part of whole body care, we can help bridge the divide between our professions and improve patient care in the long run. Whether it's adding a few simple questions or reinforcing the importance of regular dental visits, Dr. Wu, it sounds like you have confidence that our voice as medical providers carries weight and can change how seriously patients take their oral health.
Definitely. And vice versa as well. Dentists and oral health specialists needs to really routinely review patients' medical history and encourage them to receive care and screening with the physicians too. When it comes to performing any procedure, our oral health providers will really need to loop in our medical colleagues to coordinate these treatments.
Dr. Wu, this has been so helpful, and we're very grateful that you've shared your expertise with us today. Thank you so much for joining us, Dr. Wu.
Thank you so much, Dr. Nandyal. I really enjoyed our discussion today.
And a special thank you to you, our listeners, for tuning in to Cardio Radio.
This concludes today's podcast. Be sure to visit cardio.org to learn more about the Ohio Cardiovascular and Diabetes Health Collaborative.